Welcome to the Allergy and Asthma Network's 2016 webinar series titled Advances in Allergy and Asthma. I'm Sally Schessler, the network's Director of Education. It's my pleasure to welcome you today to this month's offering in our annual webinar series. We'll be inviting nationally respected speakers to join us each month to talk about issues that are important to you. Please plan to join us each month. For our June webinar, it is my pleasure to welcome Tonya Winders. Tonya is Chief Executive Officer and President of the Allergy and Asthma Network, and travels throughout the country spreading awareness and preparedness messages to patients, families, and caregivers, working with leading experts to build patient-centered collaborative care teams to achieve optimal health outcomes. Tonya has over 17 years of experience in leadership roles within the allergy and asthma industry, from sales and marketing to managed market access. A graduate of Louisiana State University, where she earned a master's in business administration, she is the mother of 5 children, 4 of whom have asthma and/or allergies. Tonya, we're so pleased to have you with us today to talk to us about shared decision-making.
Thank you, Sally, and thank you all for taking time out of your afternoon to join us this afternoon. Today we are going to be talking about a very important topic at Allergy and Asthma Network, patient-centered shared decision-making. So I am, again, very pleased to be with you all this afternoon and look forward to the discussion as we get into the Q&A period as well. So our learning objectives for the afternoon, we will certainly learn how to improve communications among caregivers and healthcare providers through shared decision-making. We'll learn what shared decision-making actually is, and you'll also learn how to partner with advocacy organizations such as Allergy and Asthma Network to secure free, medically accurate, and patient-friendly materials. And then finally, we'll learn how advocacy organizations can support local, regional, and national efforts to enhance policies and help families. So who are we at Allergy and Asthma Network? Many of you are very familiar with us, but we are truly a patient-centered multidisciplinary network that is dedicated to the same mission since 1985, and that's ending needless death and suffering due to asthma, allergies, and related conditions through our 4 core mission areas: outreach, education, advocacy, and research. Here you can see a picture of my crew. As Sally said, I am happily married over 20 years with 5 children, and they are quickly growing, and again, we are personally impacted by everything from seasonal allergies to life-threatening allergies, food allergies, as well as asthma in our family. So this is a very personal mission for me as well. So we all understand that we've been operating in a very traditional healthcare system. This healthcare system certainly has represented somewhat fragmented care. It's been focused on more of a reactive versus a proactive delivery of care and services. It has certainly been, the payment system has been a fee-for-service payment system that has in some ways incentivized a volume-based approach. We also know that in our traditional system that significant disparities continue to exist, that oftentimes, unfortunately, it is your zip code that is more a factor of the type of health care that you receive versus any other factor in your makeup. And that is really unfortunate in today's time. And we also still know that there are substantial social determinants that really dictate how people access care and how well they actually receive care. And yet we still have this sort of emerging and promise of a system that is quite different. Again, with the passage of the Affordable Care Act and the implementation of that over the last now almost decade, we are moving to what I would consider to be a more collaborative, consistent care. And again, this emerging system that is touted to be certainly more proactive versus reactive. A payment system that is emerging and changing, that is based off of value-based payments rather than volume-based payments. And then there is this promise and hope of real coordination among clinical, social, community organizations, public health, and government programs. And the key to much of this coordination certainly rests in the promise of shared data across systems, across states, across platforms, and across payers. So, this is sort of the promise of the emerging system and what we hope to accomplish through all of the changes that have happened in really the last 8 to 10 years. I often laugh and liken it to say that it's like traveling down the interstate in an RV going 70 miles an hour and trying to change all 4 tires at the same time. And naturally, we've had, some bumps in the road and issues in actually implementing and reaching the desired state of this emerging system. So we know that gaps still exist. And in fact, Allergy and Asthma Network conducted a nationwide survey this year of over 2,900 patients and 850 healthcare providers to assess what those gaps currently are. And so in asthma, what we realized is that there still are existing gaps, patient perception and HCP perception of asthma control and what that truly means, even though we've had the guidelines now for over 2 decades. Secondly, we also identified gaps in patient attitudes about living with asthma versus the limitations to activities that they've reported in coordination in relation to their asthma symptoms. And then finally, we realized through the survey results that there are varying accounts of what's actually happening during those office visit discussions. So we have some gaps between what the healthcare provider is reporting versus what the patient recalls and what the patient is reporting, as well as the difference between what's happening in primary care versus subspecialty care. So we'll dig just a bit deeper into these gaps before really getting into the solution, which we deem as shared decision making. So in this slide, you can see that the vast majority of patients actually think they're well controlled or mostly controlled. Even in those severe, moderate patients, when asked, is your asthma controlled or is it well controlled or mostly controlled, the vast majority of patients say yes. So again, across all severities, you can see that upwards of 80–90% assess that their asthma is mostly controlled or well controlled. Then when we dug a little deeper and asked about number of days of symptoms in the past 4 weeks, and we looked at both the patient-reported and the HCP perception of their patient population, you can see where these gaps begin to exist. So patients who were wheezing, coughing, short of breath, had chest tightness, daytime fatigue, or waking up in the night, sometimes 2 to 5 times per week, still thought that they were well controlled, when of course the healthcare providers said that that should only be 1 to 2 times per week, as you can see here. So again, whether we're in the well-controlled group or the mostly controlled group, you see that there is significant burden of days with symptoms. I found it very interesting that in this mostly controlled group, still they were experiencing symptoms 6 to 10 to 12 times over the 4 weeks that they felt that they were well controlled. Sally, I'm getting a message that the meeting is ended.
That's WebEx though, and we're on GoToWebinar, so I think you've got 2 things running. I think we're good.
Okay, I'm sorry.
That's
okay. So the next slide actually shows when we probe on specifics, we can identify the patient-reported asthma symptoms and how it's impacting those activities of daily living. So again, this was very interesting to us because over 80% of patients reported experiencing symptoms that affected their daily activities at least 1 time per week. And, again, for those of us who know what the guidelines say and who know the standards, and that should not be the case, that patients who are well controlled should live their lives without limitations of activities. And so here you can see across all severities that we have significant limitations even to the basic activities of walking, running, swimming, light housekeeping, vacuuming, playing outdoors with your children. Again, this is something across all severities. To see that type of impact and limitation is really alarming. And then the sufficient amount of sleep. Again, we know how important sleep is as an activity of daily living to perform optimally, and to see that 40 to 68% of patients were actually having limitation in that way was quite surprising and reinforced that there continues to be gaps and understanding of what well-controlled is. And yet, when you ask patients overall, are you satisfied with your healthcare provider, your asthma doctor, they resoundingly say yes. So 88% of patients report being extremely or somewhat satisfied with their healthcare provider who manages their asthma. And so when we dig a little bit deeper and look more at what's happening during those routine care visits, we recognize that fewer than half of moderate and severe patients say they always discuss symptoms, and fewer than a third always discuss how asthma is actually impacting their daily life or discuss an asthma action plan. And so this was very surprising again, that given all that we know about what good asthma care looks like and what the guidelines have reinforced, we still see that across severity, oftentimes we're talking about the current medications, 65% of the time, symptoms 30 to 40% of the time. But then when you get into the more objective measures like spirometry, we're certainly seeing that that's not being used routinely in healthcare provider visits. And then when you talk about even the softer side of how this is impacting the feelings and fears that one may have associated with asthma, that less than 13, 10, 4% of the time, patients are actually engaged to discuss their feelings or what means most to them. So again, we found this as really a surprising gap and also a wake-up call that perhaps we're not always asking the right questions in the right way or using all of the tools at our disposal. Because when we looked at what HCPs report during those same visits, you see that, again, they are saying, yes, I'm talking about a variety of these topics, and I do talk about half the time about those asthma effects on patient activities of daily living, but action plans are even less than that. So again, considering that those with mild asthma and moderate asthma, 53 to 63% would have an asthma action plan, and that they're discussing that on those annual routine care visits. So then we dug a little bit deeper and looked, as I said, at specialty versus primary care across severity. And again, you can still see some specific gaps. So certainly lung function testing is used more frequently in specialty care than in primary care, as well as fractional exhaled nitric oxide. But we still have significant room for improvement, even in the specialist office. Again, one of the initiatives that we've been involved with is standardization of asthma action plans, and knowing that that is a key important communication tool for patients and healthcare providers across the collaborative care team. So again, while these numbers do show some improvement of talking about the various topics that should be covered in a routine care visit, there's still room for improvement. So how can we take that next step? At Allergy and Asthma Network, we firmly believe that that next step is through shared decision-making, especially as the severity and impact of disease, the burden of disease, is greater. Shared decision-making is a collaborative process that allows patients and their providers to make healthcare decisions together, taking into account the best scientific evidence available, as well as the patient's individual values and preferences. And this is an acronym that we use for shared decision-making that really helps us to understand what that entails in more detail. So the S stands for seek patient participation and communicate treatment options. The H, help patient explore those options and compare those options. The A stands for assessing patient values and preferences, and that really boils down to what matters most to that individual patient at that time. The R is for reaching a collective decision, and E is evaluating the decision over time. So I often like to give the example of my own 12-year-old daughter who has asthma when we're talking about shared decision-making. Because if you were to ask me, as Caitlin's caregiver, what's most important to her, I would say that she can breathe, that she's safe and healthy and active, and that she can breathe without limitation to her daily activity. If you were to ask Caitlin the same question, she would have a very different answer. her answer would entail not wanting to be different than her friends, and therefore not wanting to carry that spacer or valve holding chamber, because that makes her feel awkward and different. And so what matters most to her is actually quite different than what matters most to me. And that's why it's so important in shared decision making to ask these questions and to engage in the dialogue with both patient and caregiver when you're talking about an adolescent particularly. So how do we do this? I think the first way is through engaging patients. And I often say people don't care how much you know until they know how much you care. You know, as professionals, sometimes it's easy to get caught up, and you see here all the professional groups that we work with at the network. It's sort of the alphabet soup of allergy and asthma. But the truth is, you know, as professionals, we get very busy in our day-to-day. And it's important that we stop and recognize the importance of each and every encounter and engage. When we ask patients what they want most from their asthma doctor, oftentimes it's very simple things like eye contact and authenticity. And this can only be done by truly stopping and listening and engaging in that face-to-face dialogue. At the network, we focus very heavily on how we engage both professional members and family members, personal members. We do that through health fairs and through school trainings, through all of the different channels like print, digital, email, and direct mail. And the truth is, different strokes work for different folks. So what works for one patient or family may be different than what works for another. So recognizing individual preferences and tailoring our approach to those preferences is very important. Even in how we engage the next generation, without necessarily always defaulting to those face-to-face encounters is very important, and it's one of the reasons why at the network we've begun a telehealth expansion program to really meet people where they are on their terms to receive that valid and medically accurate patient education. Certainly engaging is a two-way street. When we talk with patients and families at the network, we are always imparting into them their own responsibility for their health. And that includes being prepared for visits, coming to the visits with organized medical information, providing actual feedback, not just being a sort of bump on the log and an active participant in their health. It also includes being very honest and candid. And if you are having challenges, whether that be specifically with the treatment regimen, with the side effects, or with accessing the care that's been prescribed for you, honestly engaging your healthcare provider and sharing that information. We also think that it's very important for patients and caregivers to participate in that goal setting. This has been demonstrated to increase both self-confidence and self-efficacy. And again, we think it's a critical piece of shared decision-making and actually setting a goal that's meaningful to that individual patient and then helping them to achieve that, rather than just giving your treatment plan and expecting them to follow it. As healthcare professionals, we also have a significant responsibility in creating this two-way street. I think first and foremost, it's welcoming input and feedback, and remembering that God gave us 2 ears and 1 mouth. So asking open-ended questions and listening, asking them what's important to them. If they have specific cultural beliefs, values, or customs that may, in fact, actually impact their health outcomes. At the network, one of the things we've been surprised to learn is in some communities, the belief or fear of inhaled corticosteroids is much higher. In some families, the reticence or resistance to get rid of a pet is greater, and that has to do greatly with their cultural beliefs and values. So understanding those and tailoring the approach to those, asking those questions is very important. And then using the teach-back method. This is a very important tool for healthcare providers to actually see patients conduct their NDI technique appropriately, or demonstrate that they fully understand which medicine they should use and when. And then encouraging professional societies to include the patient perspective in guidelines and recommendations. At the network, we've been very fortunate to be a part of the NAEPP guidelines and the expert panel coordinating committee over the years. And again, we know that it's very important to always have that patient voice infused in these national guidelines and recommendations. And then maximizing patient communications. Of course, as a healthcare provider, to offer educational materials that are credible and trustworthy, but that are patient-friendly. At the network, everything that we produce, we tailor to about a 7th grade health literacy level and reading comprehension level, and we would love to have that even lower, but we know that if we can target that level, even if a person is highly educated in their particular given area of interest, they may not have the health literacy or the knowledge or understanding of this specific disease state. So it's important as a healthcare professional to have those patient organizations and helpful links handy and be able to supply them to patients at the time of that encounter. So today we're going to cover a few of the principles for effective education, what makes for good patient education. And this is all based off of adult learning principles. And again, because even if we're talking about a pediatric patient, we're engaging the adult, the caregiver. So that's why we really focus on these adult learning principles for effective education. I think that it's important to understand that there are some assumptions in adult learning principles. First, that adults are internally motivated and self-directed. We know that this is not universally the case, but certainly for the majority of people, they do have that internal motivation and self-direction, that desire to be healthy. Secondly, that life experiences and knowledge certainly influence adult learning significantly. So the truth is we all come to an encounter with baggage. We've had previous experiences that may shade this particular experience. And so being cognizant of those, being aware of those, and engaging people based off of those is really a critical way to level set and throughout a visit. And then we also come to this effective education by believing that adults are goal-oriented, practical, and relevancy-oriented. Again, if we often give patients and families the why behind the what we're asking them to do, then it will have a greater impact on their behavior. And I think that this is sometimes where the ball is dropped. So we tell them we want you to take your medication daily, your inhaled corticosteroid daily. And yet we don't necessarily provide the full explanation of why that's important and how that helps to control the underlying inflammation, and rather than just taking it at the time in which you're symptomatic. So again, explaining that why behind the what, I think, is a critical piece of effective education and shared decision making. So here you can see additional principles, adapting the teaching to the patient's level of readiness, past experience, cultural beliefs, and understanding. So level of readiness is something that I think is very important, because oftentimes when a patient is newly diagnosed, what we hear when they call the network is they're still in shock over that diagnosis, and quite honestly, they sort of stopped listening or only picked up 20 to 30% of what was said after that initial diagnosis. So understanding that patients, where they are in the journey, and adjusting that teaching and the effective education to that level of readiness and understanding is very important. I think creating an environment that's conducive to learning by allowing patients to have to really develop a full trust, respect, and acceptance, allowing patients to share their feelings, asking them how they're feeling about living with a chronic condition like asthma, is really an open door that I think that creates an environment for patients and families to feel much freer to truly open up and share some of their challenges. And then involving patients throughout the process by encouraging them to set their own goals, evaluate progress, and enhance those self-management skills. Again, we know with a chronic condition like asthma that much of the much of the management of the condition is going to be management, back in the home setting, back in the school setting, back in the work setting. And you certainly can't have your doctor or your healthcare provider with you each and every day. So allowing them to really enhance that self-management, to set those realistic goals and evaluate that progress over time is important. We've already talked about presenting manageable amounts of information over time rather than unloading the full 400 plus pages of the guidelines at the newly diagnosed visit. And then providing opportunities for patients to demonstrate their understanding of the information and practice skills, and to document all of this, because again, what we do from one visit to the next, oftentimes we will forget if we don't document well, but allowing that opportunity for patients and families to actually demonstrate and practice those skills is really critically important. So what are some of the barriers to effective education? I think that certainly we all can attest to the fact that when we're physically or emotionally tired, when we are fatigued, depressed, or where we have hearing or vision loss, it's certainly a barrier to learning. And so that is something that always should be considered. And one of the interesting things on a recent survey that we did is patients are rarely asked about if they are feeling feelings of anxiety or depression in association with their asthma. And as we all know, that can so negatively impact outcomes. And then another barrier is the socioeconomic considerations. Again, if a family can't, if they're concerned about paying their rent or putting food on the table or clothes on their children's back, then certainly these socioeconomic considerations of purchasing medication become much more trying and difficult. For some families, there's just truly a lack of support. And so recognizing that, discussing that with patients and families also is very important. I think it's also, as we've talked about, important to uncover what some of the misconceptions may be about the disease or the treatment, understanding that there may be some cultural or language barriers even in those misconceptions, and acknowledging that, paying respect to those cultural beliefs, and certainly addressing those misconceptions head on, but being sensitive to some of those particular beliefs or preferences. And then we talked again about low literacy and comprehension skills, but this can always be a negative barrier to effective education if not truly understood and recognized. We've talked a bit about the lack of motivation, and again, we sort of make the assumption that adults are generally motivated, but the reality is some are not, and that, along with the denial of personal responsibility, I would say are two things that are more challenging as a provider to deal with. They're certainly more challenging for us at the network if we're talking with families and you really realize that, in fact, if there is a lack of motivation or a denial of personal responsibility, there's only so much you as a healthcare provider can do and assist. And then some patients do come to the table with a negative past experience, so they're very suspicious or reticent to openly share some of the barriers. Perhaps they have had a negative experience, perhaps they've shared and it's come back to bite them in previous examples or experiences, and so that can also present a barrier to effective education. So this is Maslow's hierarchy of needs. I'm going to take everyone back to Psych 101 for just a moment, because I think it is important. A lot of times when we talk about asthma self-management, we really begin to talk about this whole top of the pyramid, this self-actualization. But the truth is, we have to remember that many, many families are still dealing with the very fundamental physiological needs that are expressed here at the bottom of the pyramid. The reality is, though, if we look right here at the cornerstone, it is breath. And so it's one reason why I do get my feathers a bit ruffled when I feel that asthma doesn't get the respect that it deserves, because without breath, nothing else truly matters. And so anytime that I'm talking with a family who's really having a lot of issues around some of these physiological needs, whether it be housing, food, water, sleep, all of those things, I really do like to reinforce the very fundamental need of breath and why it's so important that we recommend patients adhere to the treatment plans that have been outset by their healthcare provider. So how do we start? You know, sometimes this seems like a very daunting task. I think it's very important to identify the needs of the patient, to ask what's in it for me from the patient's perspective, because that's what they're asking themselves. What's the benefit that I'm going to get out of this? So gathering information about their daily activities, their knowledge, beliefs, and level of understanding, and then tailoring the education to meet those, presenting it in a very clear and concise format, but discussing the treatment plan in terms of specific behaviors rather than just the general, this is the medicine that I want you to take, and here's when I want you to take it. You know, for my daughter, we've talked about things like taking her medication when she's brushing her teeth on a daily basis, or when she's applying her acne medication, which at this point is more important than the asthma medication in her hierarchy of needs. So, you know, identifying those specific behaviors that can improve adherence is very important. We talked about identifying the barriers and addressing them directly, encouraging questions and providing appropriate answers, not giving them the full Monty of everything in the 400-plus page guidelines, but definitely tailoring specifically to that individual question and addressing the concerns that may be voiced. And then using interpreters effectively to facilitate communication, but also utilizing appropriate written, audiovisual, and computer-based materials. So we often recommend that as a healthcare provider, you develop a library of evidence-based patient education materials. We have a wealth of these at the network, and I'll share a few of those in just a moment, that you select those materials based off of that readiness and level of understanding, that you develop systems in your office to reinforce this patient education. This shouldn't always fall on the healthcare provider. Patient education can start the minute a patient walks through the door, or even before they step foot in the door. And certainly after they leave your office, you can continue to communicate patient education and reinforce those best practices. Utilizing family support systems is always a good way to reinforce these implementation and education tips. And being aware and utilizing emerging technologies, whether that be through email reminders, through text reminders, through appointment reminders. We have a mobile app that actually helps patients to track their symptoms over time and also to track their medication use. So there are all sorts of emerging technologies that are very critical to help patients to more effectively self-manage. And then teaching patients what is a credible source and how to find those credible sources, because as we all know, everything on the internet is not trustworthy or credible. So it's very important to connect them with appropriate credible sources. So at the network, some of the sources that we have that are, again, available to all of you on the call today, our Allergy and Asthma Today quarterly magazine. It's read by about 2 million each quarter. Everything is medically reviewed, but written on a 7th grade health literacy and reading comprehension level. We also have our Understanding Asthma, Understanding Allergies, and Understanding Anaphylaxis guides that have just recently been updated and reprinted. So we have those both digitally and in print and can supply them for your practice, for your support group, or even just for your family members who may need a greater understanding. Each is about 36 pages and covers the very basics of diagnosis, treatment, and self-management of each of those conditions. We also have our electronic newsletter that is distributed every 4 weeks on the hot topics in allergy and asthma. And we have our poster series, which was updated in 2016, is also available in English and Spanish. At the network, we do focus on a multi-channel approach, whether that be online, digital communications, email blasts, certainly social media. We really engage and meet people where they are with those guidelines-based messages that are presented in a patient-friendly format. And we also do so in a multilingual format, both English and Spanish. And we're hoping to begin to even invest in some resources that are in Mandarin, Chinese, Farsi, and French. And then our website is actually tailored and targeted to specific audiences. We have a section for healthcare providers as well as for patients and caregivers. These are a couple of our resources that I mentioned earlier, the Understanding Asthma and Understanding Allergies Guide. These are the posters. And then we also have educational programs like our Anaphylaxis Community Experts Program that has conducted over 7,000 events and trained over 100,000 people in the last 6 years of its existence. We partner with the American Academy of Pediatrics on their Champions Program to help pediatricians across the country reinforce those guidelines-based messages as well. Our Convenient Care Clinic Training Program is actually for the CVS, Walgreens, and Kroger little clinics, and the nurse practitioners and pharmacists who work within those settings. And then we also have our Women Breathe Free, which is a telephone counseling program for women, specifically our families who are at high risk for ER visits and hospitalizations, where we do a more in-depth motivational interviewing technique and then a follow-up to address the barriers that are identified and help those individuals to enhance their self-management skills over a 4 to 6 week period. You'll see here we also have several programs working with asthma camps across the country. We developed the Asthma Camp Educational Program this year, and all 3,500, 4,000 campers throughout the country will be receiving that program, or are receiving that program this summer. So we believe that an educated patient ultimately should become an empowered, advocating patient or family. And we do this through creating policies and also through hosting our annual Allergy Asthma Day on Capitol Hill. We just completed our day in 2016 on May 12th, and we do this each and every year the second week of May, and would love to have you all join us at a future event. An opportunity for we as a community, for stakeholders to come forth and to share with federal decision makers the concerns that are facing our families in regard to access to medication, safety of medication and treatment, as well as some of the policies and reimbursement and access to care that would enhance and help us to achieve those optimal health outcomes. We work with the Allergy and Asthma Congressional Caucus and host quarterly congressional briefings on a variety of topics that are important to our community stakeholders as well. This next slide actually shows some of the federal legislation that we have currently been working on, as we talked about with the telehealth expansion, as well as with EPA's Clean Power Plan and Clean Air Act, reinforcing that it's both indoor and outdoor air that can significantly either enhance or really prohibit better breathing for families. And then we are very excited about a current legislation, the SAMPRO, School Asthma Management Program Act, which actually would provide for standardized asthma action plans and stock albuterol throughout the states in the U.S. And so, again, you can see we're very active on both the federal front and the state front of ensuring access to medications, including albuterol and epinephrine. We also encourage patients and families to raise their voice in the regulatory process, whether that be at FDA or at the Federal Aviation Administration, with things like including epinephrine autoinjectors in the emergency medical kits. So this is an example of how when patients and healthcare providers, when the community comes together, what can happen. Just a mere 2.5 years ago, this map was actually primarily red, where there were very few states that had stock epinephrine in schools. And now today there are 49 states that actually have stock epinephrine permitted in the school setting, so that if a child has their first anaphylactic reaction in school, they have access to medication. I think another way that we've tried to implement policy is through stock epinephrine in public spaces, and you can see that, again, this is moving where it was once all red just a mere year or so ago. Now we're beginning to see about half the states, again, turning green, that allow public spaces to now stock epinephrine. And our next advancement of policy will emphasize stock albuterol in the same way. The final area that we talked about of outreach, education, advocacy, and research. We believe that every patient should have the opportunity to be involved in emerging research, whether that be market research on beliefs and perceptions and outcomes, such as the Open Asthma Survey that I shared at the beginning of our time today, or if it is actually participating in a clinical trial. And so we are participating in a couple of PCORI projects in asthma and severe asthma, and also are working across the spectrum with Research America and others to raise the awareness and engagement of patients in the R&D process, clinical phases all the way to commercialization. The reality is, though, we still have a lot of work to do. Unfortunately, 12 Americans die each and every day because of allergies and asthma. And every time I say that statistic, it really stops me in my tracks and resonates with me, because these are families just like mine, just like many of yours, who never thought it could happen to them. We have great guidelines. We know what works for the majority of patients. We have emerging treatments and technologies for even the most severe patients in the pipeline and coming to market. And yet 12 people die each and every day in this country because of these conditions, 10 due to asthma and 2 to life-threatening allergies. So how do we close these gaps? How do we move from the traditional system to the promise of the emerging system? How do we close the gaps of communication, control, severity, and routine care visits? We believe that we can do that, but it is a collective effort. It's a two-way street between patients and healthcare providers, and it's best done through shared decision-making. So with that, I think that is my last slide, and I will open it up, turn it back over to Sally.
Okay, well, I just have a few announcements, and then we're ready to take any of your questions. So now is the time to enter those into the question box. But first of all, I'd like to say thank you to Tonya. You've really helped us see how to incorporate that patient voice so that they can have that voice in their own care. I'd like to ask you all to be sure and register to join us for the remaining webinars in our series. The next one will be on July 20th at 7 p.m. Eastern Time. Dr. David Golden will join us for our program entitled Insect Sting Allergy, To Worry or Not to Worry, and What to Do About It. Our webinar series helps the Allergy and Asthma Network to live out our mission to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. So we do have a couple of questions. One is, can you speak to any of the Medicare and Medicaid reimbursement policies related to asthma management?
Yes, absolutely. Great question. So in January of 2014, CMS passed a provision that does reimburse for environmental in-home assessments and environmental remediation. And so that is a reimbursable service through CMS. Now, at the managed Medicaid, at the state level, that has not been universally accepted and has not been universally applied. So that is an effort, especially from an advocacy perspective, that we are working with specific states to advance. So again, I would encourage you that if you have a challenge in your own area in regard to access for reimbursement for both asthma education and or in-home assessments and environmental control, that you reach out to the network, and we'll be happy to assist you in those advocacy efforts and provide support.
Okay. As a parent, how can we educate other families in our children's school?
You know, it is about a community, and I think that it is critically important that we use these types of tools that we've talked about today, these types of methods, to really engage our community and to help, quite honestly, bust some of the myths around these conditions. So what we often say is, if you can get even a group together, whether that be at a church health fair or at a PTA meeting, or even just a group of people together that you would like to raise the level of awareness about the disease, we are more than happy to ignite our outreach coordinators, our anaphylaxis community experts, and our community to come around you and to support you with those types of presentations and educational tools that would enhance their understanding of the burden of the disease, of the reality of the disease, and how they, as just a community stakeholder or concerned citizen and part of the community, can support those that are living with these chronic conditions.
Okay, we've got a lot of questions about, is the webinar being recorded and is it going to be available? And yes, the webinar is being recorded, and it will be posted in the education section of our website at allergyasthmanetwork.org. Look for the tab that says Education, and then click on Webinars, and you will find it there. We do not provide the slides to people, but we do have the recording of the webinar, and so that is something you will be able to access. We usually have it up within 48 to 72 hours. And the next question is, how can libraries be good partners with physicians and patients? Many hospitals have libraries with consumer health information, but they aren't always utilized by patients or recommended by physicians.
Yeah, that again, that's a great question, and one that I think is very challenging, because I agree that most of our healthcare facilities have wonderful resources, and yet how do we get them in the right hands? And I think by again, perhaps partnering with the specialists in your community and ensuring that they are aware of the resources that you have available, and reinforcing, not just telling them that one time, because quite honestly it takes multiple times, multiple engagements, multiple reminders to actually get them to change their behavior and begin to use them. At the network, we've had the same mission and worked within the same community since 1985, and I'm always surprised when someone says, "Oh, I didn't know you did that. I didn't know you had those resources." And I'm like, "Yeah, well, we've been doing the Allergy and Asthma Today magazine for now almost 20 years." But just continuing to reinforce that, continuing to help raise the awareness and the recognition that those resources are available is critically important. And another thing I would say, the network could help if you are in a specific target market and you would like for us to highlight the resources that you have in your particular system or area. Contact us. We'll be happy to do a push message out to all of our members within your specific geography.
And Tonya, someone is asking if you could tell them again how they can actually access the resources you're discussing.
Absolutely. So you can visit our website, which is www.allergyasthmanetwork.org. Again, that's allergyasthmanetwork.org. Or you can call our 1-800 number at 1-800-878-4403. Again, that's 1-800-878-4403. You can go on our website to our online store and order those resources, or call, and again, we'll be happy to send those out. We typically just charge shipping and handling. There is no fee for these resources as healthcare providers and families who are working to educate and raise awareness in your own communities.
And another question is, what legislation do you anticipate will be the biggest lift next year?
Oh boy. Well,
pick one.
let me get my crystal ball out. So it's really funny. It's a very interesting time in DC. I personally am one who cannot wait for November to come and go so we can get back to business, and hopefully make some things happen regardless of the way the election transpires. So right now, as I said, the main emphasis and focus is definitely a big lift is on telehealth expansion and ensuring that families have access to respiratory care services and asthma education services through telehealth, so that I wouldn't have to take off half a day to go see my doctor or see my asthma educator and have an educational lesson, that I could do that remotely over a video chat. Is very critically important. I think that legislation to, as we said, incentivize states to pass stock albuterol will continue to be a critical issue for us in 2017. Although we do have the active legislation now and it is moving and it has a number of co-sponsors, I am realistic about the challenges of it getting passed before Congress goes out of session. And so I think that we'll have to reintroduce that in 2017 and pick up the ball and begin to gain momentum in 2017 to actually get that legislation passed to create an incentive for states to have stock albuterol in schools and then ultimately in public spaces.
Well, I think, Tonya, we'll probably want to encourage people that there's such great power in the voices of all of us that are interested in this space with stock albuterol. I think that with stock epinephrine having passed in the schools, stock albuterol could certainly ride the coattails. But when we had our Allergy and Asthma Day on Capitol Hill, it was amazing how many, with all of our stakeholders and partners visiting their legislators, it was amazing how many more co-sponsors there were to the bill after that experience. So I would just like to encourage people to be sure that you raise your voice for these issues. It doesn't take long to contact your legislator, but certainly every voice counts.
It does, and it's so very important that you lend your voice to those advocacy issues. And then also that at the state level, I mean, you know, there are states that are already moving ahead, even in the absence of the federal policy. We're seeing states begin to introduce and pass their own stock albuterol legislations. We actually have a pilot program that will launch in Ohio and Georgia in the fall of 2016. Because those states have already passed that legislation. So again, we don't have to wait. If you have a specific connection at your state legislature and would like to advance these types of policies, please don't hesitate to reach out and to let us know, and we'll be happy to support and engage along the way.
Okay, another question. Is there a statistic for the percentage of asthma attacks that lead to emergency incidences?
I haven't seen a statistic specifically about the percentage of attacks that lead to ER visits. I'm not sure that there is good data on that particular metric. Now I know that, again, you know, we have 144,000 missed school days. It is the #1 reason why children miss school, and subsequently one of the major reasons why people miss work every year. Of course, we know that the rates of morbidity and mortality has continued to increase and somewhat plateau. But thankfully, we're not seeing those mortality rates that we did have in the 80s, but we're still seeing a very significant morbidity and certainly cost at $56 billion annually of direct and indirect costs due to asthma.
Okay, I think we'll make this our last question. How much time to give to shared decision-making in a patient appointment?
You know, this is the challenge, right? So we know best practice, but the reality of a 7 to 10 minute office visit is constantly breathing down our necks as both providers and patients. So I think that the key is how do you implement many of these things throughout the entire course of the visit, whether that be from the moment they walk into the waiting room, before they arrive. How do we identify and ask these questions so that the 7 to 10 minutes of actual face-to-face time with the doctor, with the healthcare provider, is more beneficial? And so I say that shared decision-making really shouldn't begin in that 7 to 10 minute visit. You know, that should be the culmination of the shared decision-making. But the reality is we certainly know that in today's, you know, very time-constrained environment, that it's a challenge. It's not easy. And it can't happen in just one visit. It really has to be working with the patient throughout their journey, meeting them where they are every single step of the way, but never taking the human heart and factor out of this. Again, when we ask patients, what do you want most from your asthma doctor? The word authenticity continuously comes up. And it may be disguised as eye contact, or I want them to ask me about my feelings, or, you know, all of these things. But ultimately, it's I want a true human engagement and not just a rushing to get to the next room.
Oh, thank you so much. I would just like to draw your attention to our final slide today. The network is having 3 U.S. anaphylaxis summits. We've done this for years now, and these are fabulous one-day conferences. They are open for registration in 3 great cities. We'll be presenting these in September and October in Las Vegas, Nevada, St. Louis, Missouri, and Orlando, Florida. And our sites this year are great for some personal and family vacation time, as well as a great time to address important issues that affect so many of us or those we care for. We've worked to spread these conferences out so one could be within reach of you. If you haven't been to a U.S. anaphylaxis conference before, they are unique. There's no registration fee for the conference, and we have people from all walks of life, physicians, allergists, health professionals, nurses, parents, and patients come together to listen to the latest health information and research from leading national experts, and then have a multidisciplinary conversation about the challenges and solutions related to anaphylaxis management. Our agenda for the day is there on the side. I think these are just, I went to these conferences before I actually worked for the network. I think they're amazing, and we'd love to have you join us for one of these. So again, thank you to Tonya Winders for sharing your expertise today. This is Sally Schessler, Director of Education, and on behalf of the Allergy and Asthma Network, thanks for joining us today.